We are honored to have Dr. Albert Kim of Washington University in St. Louis, Missouri, joining us to present findings from a recently published paper, 12-month outcomes and quality of life after brain tumor ablation. Authored by physicians at 14 leading academic medical centers, the prospective study involving 223 brain tumor patients is the largest of its kind, detailing beneficial results following minimally invasive laser interstitial thermal therapy. Dr. Kim is the director of the Brain Tumor Program at Washington University School of Medicine. He serves as the surgical director of the Pituitary Center and is associate professor of neurological surgery, genetics, neurology, and developmental biology.
Great. Thanks very much for everybody joining tonight. I know everyone's probably in some new bizarre ways busy right now, but I think this is an important topic, and this has really been an investment by a number of collaborators, Monteris for sure, who helped us make this investment, and a lot of really friends, colleagues across the country who provided data for this important study. So I'm going to talk mostly about this LAANTERN trial, quality of life outcomes, and our 12-month outcomes. But I'll reference this paper and another earlier paper by the same group, Rennert and others paper that really talked about the safety. But we'll primarily be talking about this. And I know it's later in the day. People have probably had busy days, whether in clinic or the OR, or maybe doing other things with the family. And so I want this to be interactive. So I'm going to stop quite often. I know a lot of my co-authors are on the line as well. If anyone has opinions either about this or about their lit experiences more generally, I welcome you to talk about that. Okay, I want this to be, again, as interactive as possible. This is just the long and short of this is that we're going to talk about the NeuroBlate system by Monteris, which uses a 1064 nanometer laser, and we're going to talk about primarily one paper about the quality of life after laser. And this is great data because quality of life data is tricky. You can't do it retrospectively. People are going to have some significant biases if you ask them after the fact. So this is all data collected prospectively, and that's really a key feature of the data set. So if you PubMed lit now, it's kind of crazy. I mean, it was almost 0 papers in the early 2000s, but now there's been this exponential rise. Actually, the new form of PubMed allows you to do this. You can look at how many papers per year for a certain topic or a given author. It's quite interesting. And this reflects if you did that now. I mean, it's incredible. The number of papers continues to grow. And if anybody would like to see some of these papers, I think there is a very nicely organized set of references that address various things, whether it's tumors like this study or epilepsy or radiation necrosis. We can make that available to you if you either ask myself or some of the crew at Monteris. All right, so what are we talking about? We're talking about the LAANTERN trial, and that's really a prospective database that's collecting in a multi-center way real world data. It's not like cherry-picked data. These are cases that are actually happening. I think the idea was that prospective randomized trials are just very difficult given the number of histologies out there in CNS space. And so you could really get some useful information for more rarer diseases like in neurosurgery if you have prospective registries. And so that was the idea. And so the goal is to actually get 1,000 patients. I think at the time of this manuscript being written up, we had enrolled already 500 patients. And what we're going to do is basically look at those 500 patients and look at a subset of them, specifically the tumors. So we're looking at local control, progression-free survival, overall survival, seizure freedom. We're not looking at necessarily all of those in this specific study, but these are the types of data we're collecting. And then for quality of life, we have 2 different metrics for quality of life that have been validated in the literature that we'll be looking at. And the LAANTERN sites for this study, there are 14 sites, but they're we're basically aiming for up to 50 sites. And so this has been a great collaboration. It's been a lot of fun, frankly, to work on this study with my colleagues. And so let's talk about the study outcomes. First of all, this is a prospective study. It's the largest and really the first of its kind, detailing the 12-month outcomes of laser ablation for brain tumors. And so we'll look at a few different metrics. First is safety. Again, we hit upon this in an earlier paper by Rennert and others, but again, we'll look at this. The safety profile of the laser ablation remains consistent in this study with or favorable to previous publications, and is similar to about the 5 to 7% complication rate that people would typically see for instance, a needle biopsy. And then there are other metrics we're looking at right now. There are certainly healthcare economic metrics we can look at. And in fact, in other studies, in one study by Eric Luthart, for instance, he showed that in certain histologies, in particular, like metastatic disease, in another publication, that lasers, in fact, economically favorable compared to craniotomy. But in this study, we'll be looking at things like length of stay, readmission, and cost. And then we'll look at the quality of life metrics, and we'll go over that a little bit because I personally am not super familiar, at least before this paper, I wasn't super familiar with the different metrics involved, and I hadn't taken them myself. And that's something I did as part of this manuscript. And then we'll look at survival, overall survival for the most part in some of these cohorts, okay? All right, so we're gonna be, out of the 500 patients enrolled so far, we're gonna look at 223 subjects. I think among those, we did laser for, I think somewhere in the vicinity of 230 tumors. So it's some people had multiple tumors, a minority of them, but some people had multiple tumors that were ablated at 14 different medical sites. And again, this is the interim analysis. These are procedures performed within a 2-year period, 2016 to 18. The median follow-up was about 223 days. And the median age of the entire cohort was something you would expect in people with primarily malignant primary tumors and metastases, mid-50s, something like that. And the median baseline Karnofsky score was quite good. It's about 90. So people who generally could take care of themselves. And so here what we're seeing is that basically just over half of these people were primary tumors, about 60% of them. And we can go, and then Mets about 40%. So to get a little more granular about this, for the most part, when we're talking about Mets in this study, they're previously treated Mets. I think if I remember the numbers, it's something on the order of 93% of all the Mets here are really medically refractory or treatment refractory. About 82% of the prior metastases in this LIT study were treated with SRS. And so we're talking again about like SRS or treatment refractory metastases for the most part. When we're talking about the primary tumors, the grand minority actually were grade 1 and 2, just 15% or so were like grade, very low percentage were, I'm sorry, it's even 7, maybe 7 here are grades 1 and 2. The grand majority of the primary tumors were grade 3 and 4 tumors, and mostly recurrent in that group, I would say. Now, I guess, does anyone have questions generally about the characteristics of the group? Any questions about that? One question I get when I show like a figure like this, or I talk to people about this study, they ask me, okay, all right, now we're talking about recurrent GBM, let's say. Are we talking, first of all, we put grade 3 and 4 together, at least for the purpose of this study. The data weren't coded to distinguish 3 and 4 for the quality of life metrics. So people, wonder, for instance, how about if we take the subset of recurrent IDH wild type glioblastomas, what does that look like? What does QOL look like? How about for IDH1 mutant, newly diagnosed, what does that look like? I think these are studies that are ongoing and are going to be very important. But for the most part, that level of granularity is not going to be in this data set. But that will take considerably more work, important work, but that's sort of in the pipeline. So I just wanted to mention that. Now, most of these tumors were supratentorial. This just gives you a breakdown of where things were. I think, for instance, insular tumors are included here, and they're probably going to be in the frontal bucket. As for myself, again, I probably do, for the most part, supratentorial lesions still. At WashU, at least, we've almost completely moved to a ROSA-based system, a ROSA robot-based system, because of its accuracy. I mean, you can literally do a pull-up on that thing, and the accuracy won't be any different. And so the stability of it is really the asset. I think with the ROSA system, Dr. Luthard and I are seeing more posterior fossa type ablations. I think, you know, MCP, basal brainstem, and cerebellar ablations are feasible, just because some of the other platforms are not as stable. I think maybe the one exception to that might be something like a StarFix custom platform system. So, but generally, we're still doing the mostly supratentorial. I'm curious, among the people out there doing the lit, has that been mostly your experience, mostly just supratentorial? That might be just a proxy for how metastases tend to be supratentorial anyway, as well as gliomas.
So I was just wondering, back at your brain tumors that were metastasis,
Yeah.
Especially with lung, we're seeing more targeted therapies that are having some astounding results. So I'm wondering, did you, in the data, collect that information so that you can essentially account for that in your analysis, that they did or did not have a targeted therapy?
Yeah, no, you bring up a really good point.
Multi-layered.
Yeah, I agree. It gets complicated, particularly for, it's the same for recurrent GBM space, because there's no standard of care in that space. So everyone will be on a trial or, you know, or some series of things that ultimately lead to Avastin and other things like that. That data is there. It's not reported in a granular fashion in this particular study. What I can say about our personal institutional data is that most of our Mets did not have targeted therapy immediately after. I think there's certainly a number of people with immune therapies. By the way, I think the great majority of the metastases that were treated here, again, like I said, they're mostly SRS resistant or SRS failures. And then most of those were lung, like 61% or so were lung, followed by breast. So it's mostly lung, and then maybe half of that number breast cancer. But I think you're right. I think especially like things like osimertinib and all these other, you know, ALK fusion inhibitors and things coming up, I think that's going to be really important moving forward. It's going to certainly complicate the analysis, but it's important. I agree with you.
Thank you.
I mean, the other interesting aspect of that is, and again, this is a little different from what we're going to be what we're talking about in this study, is that the laser ablation in an earlier publication in a human study by Eric Luthart and myself, and more recently now we have a paper basically that's essentially been accepted in a mouse model of laser, that you could actually get more targeted therapy or chemotherapy into the brain during a period of about 4 weeks or so after laser. So I think it'll be even more complicated what you're talking about, you know, because it's possible, like, you'll have a drug that is targeted and has, you know, maybe something like 30 to 50% efficacy in the brain. If you do lit, that medication will be substantially more permeable after that for a couple of weeks. So I think there's some interesting things that we need to test moving forward. Thanks for the question. I was wondering if how other people's experiences with posterior fossa is. Like, have you been doing a lot of, you know, lit for MCP, brainstem, cerebellar hemisphere, and what kind of platforms do people use for the posterior fossa? I mean, we've been using different things. That we were initially using Stealth Vertec for our targeting, and then we were using StarFix in particular for the posterior fossa because it's again, it's a 3D printed configuration, which is interesting, and I'm happy to take questions about the StarFix platform if people are interested. But now, just because the ROSA robot platform is just so stable and so easy to use, I think we've gravitated towards that for the posterior fossa, and now Before I was apt to use, for instance, Vertec for the easier supratentorial trajectories, but now I think the ROSA is just a lot more stable, so I'm just using that for all of my cases. So some of these health economics and safety metrics are quite interesting. In fact, I would say as an introduction to this slide, laser ablation might be the perfect tumor ablative technique for the COVID-19 era. I could tell you what we're doing currently in our hospital now. And so I would say these numbers are going to be pushed even lower in terms of length of stay. So in the study itself, the median length of stay was quite good. It's like about a day and a half, 33 hours or so. I think if I remember the numbers, the average length of time the procedure took was about 190 minutes, just over 190 minutes. So just over 3 hours for an ablation. And the adverse event numbers were quite low, and in particular, 30-day readmission numbers were very low, 1.8%. That's astoundingly low, actually. But I would say that for us here in St. Louis, the hours length of stay in the hospital are even lower. So, for instance, over the last 2 months, what we've been doing is having people come in, get their laser. If they get it in the morning, first of all, they don't go to the PACU. They just go. They don't go to the ICU. They just go to the PACU, and then en route to the floor, they get a CT. If that CT looks good, they remain in the floor, and they can actually leave later that day. If I have any concerns, maybe their neurologic deficit is slightly worse, maybe because of the anesthesia, maybe because of the procedure, I'll actually have them go the next morning. And so I would say when people are going home or home with PT, they're either leaving the same day right now with no ICU stay, or the next morning, again, with no RCU stay. Generally speaking, we've been doing MRIs post-operatively, but just because of all the craziness of the coronavirus, we haven't been doing immediate post-op MRIs just to decrease their exposure time in the hospital. And the only time that people are actually staying greater than a day, honestly, is when they need to go to rehab, and that, of course, takes things like being assessed by physical therapy and occupational therapy, and then some certain providers mandate a certain number of days in the hospital before you're allowed to go to rehab. But I would say in the great majority of cases, for me, maybe only one person went to rehab. In my lit cases over the last 2 months, everybody else went home either the same day or the next day without going to the ICU. Does anyone have any questions about that general workflow? I think it really is reflected in these numbers. Again, this is even more extreme because of the coronavirus. It's going to get even shorter with the length of stay. And this is related to what I was just talking about anecdotally. So most of our people after lit, and this is just across all 14 institutions, are going home, and that's pretty incredible. About 83-84% are going home, and a great minority are going to either a rehab or a SNF. As you can see here. And so I think that's great. I mean, one way I put it to patients who are going to get this therapy, it's something, essentially, it's like something we can get away with, is what I tell them. They don't feel like they've been really hit as much as a craniotomy, probably because of the extent of tissue damage, I would hypothesize, and the inflammatory reaction related to that. But I just don't think it's as much of an insult for their bodies, and that's why you're seeing that reflected in their dispo. Okay, so now let's talk about the really the main event behind this publication, the quality of life indices. And so this is something we should probably do better as a field, honestly. We talk about our extent of resections and PFS and OS, but people are really concerned about whether they go back to work, if they have social isolation or are able to take care of themselves. Are they seizure free? Are they driving? More of these functional type of outcomes. They're certainly important, in particular for diseases that are less aggressive. And so I think this is really important. So these are two vetted metrics that people have used in the past for quality of life. The first is more a holistic one. It's called EQ5D. I think it's like version 3. There's a version 3 in that, and for the actual one we're using. There are a number of different versions, and that looks at a number of different outcomes. They're listed here: mobility, self-care, usual activities, pain and discomfort, anxiety, depression, visual analog scale. Now, if you're a brain tumor patient and you look at, like, you're asked if you want to answer a questionnaire. I mean, I would imagine it's the last thing you want to do, honestly. Like, you're tired and you're getting treatments and you're scared. But I personally looked at these questionnaires. They're quite reasonable. I would say the EQ5D is like a page, if I remember, and it's just like check boxes like, are you able to move well? Is your moving limited? And it's just a bunch of check boxes that it's essentially a page. The FACT brain is more brain tumor specific. It has to do more with sort of functions related to your brain. But even that's not onerous, honestly. They have things like emotional well-being, social functional, total well-being, but it's really like, sort of categoricals for each of these, like, four or five different categories for emotional well-being. And so again, it ends up being a very reasonable, short kind of a questionnaire, like a page and a half. So I personally did these myself, and they're completely reasonable as questionnaires. We don't want these to be onerous at all to patients, obviously, but we still need to get good data. I will say that, first of all, people wonder about, how does the baseline look? And I think it's down here below. The baseline data for this group of people getting laser, the baseline data is about the same for the EQ5D as with the people who are getting craniotomy. So I think that's good. So it's not some, it's not some outlier data. It's very much in line with what people have seen before. And then the positive data is really on this first line. So for the EQ5D, there were improvements in mobility, in reported mobility, self-care, and usual activities. And then for the brain-specific QOL, there was increased emotional well-being months after the procedure. And just to give you an idea of when we were administering these questionnaires, I think it was like 1, 3, 6, and 12 months, for instance. And so this is based on each of those time points. Now, there weren't really any clinical changes in pain, discomfort, anxiety, depression, or visual analog scale, and there were really no clinical changes in social, functional, or total well-being scores. I think that's pretty remarkable, honestly. I mean, these are people with, I would say, either advanced disease or medically or treatment refractory disease. Actually, what I'll get into just in a second is also other aspects of these patients when we look at some of the survival numbers too. But I think basically they're people with advanced disease. I mean, not only local disease, but systemic disease that, that might not be, but that might be bad in the case of metastatic cancers. And so I think these data are quite favorable in that setting.
Yeah, so we're working on starting to collect quality of life data and looking at different outcome measures. So why did you choose these ones in particular, instead of SF36 or PROMIS? And what's your workflow for collecting this data?
So, I have to say, I am familiar with PROMIS as well as, I'm not as familiar as the first one you said. I think part of the idea of choosing these was sort of the level of burden of these metrics, number one, and then they are vetted, and we do have data in other data sets, for instance, for EQ5D and for FACT brain in the literature. That's part of the reason, and frankly, I took it, and it was a very reasonable, doable thing. It is better if you get more granular data for sure, and I guess, actually, what are your thoughts about these particular metrics?
I have not looked at the FACT BR thing. The EQ5D was definitely easy.
Yeah, for sure.
And then you have to get all of the attendings to agree if we're going to do it for all patients. So, right.
Yeah. But you should take a look at FACT brain. I actually just looked at it again over the last week, and it's very quick, and it's certainly more neurologic in its specificity. So I like that aspect of it. But I think the other ones you talked about, I mean, we had been using PROMIS, I think, in our clinic at WashU, particularly for spine, but it was a little longer for sure, was one of the reasons. And in terms of the workflow, actually, I think the investment of, and I'm not trying to oversell this, the investment of Monteris and then sort of the buy-in of the academic centers has really helped. So basically, I have a laser patient and sort of the clinical trial person specifically associated with LAANTERN just shows up in my clinic in advance of that person. Like I'll see that person in an hour and the person's already there, ready to enroll this person. And then they basically get the questionnaires moving forward in time. And so there's already this wonderful machine that gets it prospectively. So it's been automated. That's been a super, convenient aspect of this particular study, because that's really hard. I understand.
Yeah, so you're only collecting data for these specific patients, not for everybody.
That is correct, yeah, because we have this additional staffing that really makes it a lot more manageable, because it is hard, right? I mean,
it's work.
Yeah, for sure. I completely agree with you.
Hey, Dr. Kim, good talking with you. I was just curious, with the heterogeneity of this group, and I don't know the answer to this question, are these quality of life metrics able to distinguish someone with lung cancer quality of life versus compromised quality of life from breast cancer and so on? Because it affects each different disease process will affect someone's quality of life in a little bit different way. And some of these metrics may highlight or not highlight the different disabilities the patient's experiencing.
Yeah, no, I absolutely agree with you. And I think this is a weakness of the study. I mean, it is amazing that it was physically done. I think it took a ton of work. But I agree with you. Like I said before, the ideal would be to say only lung patients, actually even mutationally specific, or only recurrent GBM, IDH1 wild type after lit, all with a sort of monolithic, consistent care would be the best. I agree with you. But I think this was basically a first pass at sort of a proof of concept that we could physically do this in a registry. I think the statistical, or I don't know if it's statistical, but the sort of the basis for us at least being able to compare across, or looking at QOL across, was that the survivals were approximately similar here. And I would argue that this is a group of patients that generally was just a poor sort of prognostic group of patients, given that they were advanced disease, refractory disease. Also, it turns out like the average BMI was like 45 or 46, and they all had a major comorbidity. So I think it is heterogeneous, but I would say it probably skews towards a little more a sicker side. And so I think even with that, they tend to be sicker, and the survivals are quite reasonable. And so we thought that at least at this level, putting the QOLs together for the first manuscript would be at least give you something meaningful. But I completely agree with you.
What your steroid use is intra and post-op?
Yes. So I would say it differs depending on the individual somewhat. And it's rapidly changing, actually, particularly if you're tying laser to immunotherapies in clinical trials, for instance, which we are, and I know a number of other institutions are, for instance, Case and I think Sinai as well in New York. So I would say typically the taper looks very similar to after a craniotomy. I would say on the order of 1 to 2 weeks. But me personally, I accelerate the taper when I need to get the person onto, for instance, PD-1 antibody or something like that for trial. I try to really get it to, something on the order of 1 BID as quickly as possible. But I would say, yeah, it's probably on the order of a week or two. I think at the beginning of people's experience, because there was swelling that was evident on the post-treatment MRIs, people were a little leery of tapering quickly. So I think at the beginning of the technology, maybe on the order of 5 to 10 years ago, people were doing slower tapers, like on the order of 2 to 4 weeks, 2 to 3 weeks. But now I think we're about 1 to 2 and even more rapid with immunotherapy.
So one of the reasons that we have 2 questionnaires in the registry is because it's recommended that you have a disease-specific questionnaire and then one that is more generic. And that was something that I learned in working with some of the statisticians that, are really experts in these types of projects. I think the other thing to note as well is that the brain tumor specific questionnaire is really specific just for the brain disease. So if it is somebody that has a MET, it doesn't take into account the primary tumor going on in the rest of their body as well. So again, these, like Dr. Kim mentioned, these are shorter questionnaires, which are really easy, hopefully, to implement in the clinic. But with continued gathering of evidence, we really need to have baseline in order to compare to the follow-up visit as well, and increase that sample size so we can do more of those sub-analyses. But really great questions.
Talking about overall survival, again, I would emphasize that I think again the BMI, I think the median BMI maybe was 45 point something in this group, so high, and I would say the overwhelming majority of patients had a major comorbidity. And I think mobility was also quite diminished. Something like a quarter of the patients had diminished mobility overall. And so I would say that this is a group of relatively sick patients with advanced disease or refractory disease, like I said. I know it's not really fair to compare, apples and oranges here, but primary tumor in terms of the overall cohort, and that's mostly grade 3 and 4 tumors, which were refractory, and metastatic tumors here, which were 93% or so refractory to first-line medications. You see, you haven't even reached the median survival by 2 years, which is actually quite remarkable generally. Again, it doesn't say anything about the granularity of it, and I completely agree with those out there saying that, I really need the mutation-specific, stage-specific overall survival. But I would say for groups like this, and in particular the metastatic tumor, that survival curve is pretty favorable with LIT. Any questions about that? And so essentially, just to sum up, the safety profile of LIT is, in this study, was consistent with other studies. Again, it's very similar to that you would encounter with stereotactic or needle biopsy. Length of stays were favorable compared to other modalities like, I would say, craniotomy, as well as readmission rates and costs were generally favorable. Again, I would say emphasize that length of stay across 14, and a lot of people, many neurosurgeons tend to be conservative about their length of stays and things like that to this day. So I would say the overall group having a length of stay of 33 hours is really good. I mean, it's better than a day and a half. And then again, this is the first published quality of life. There are certainly caveats as has been raised today by some of our participants, and I think they're really important points. This is really a baseline set of data, and I think the subset analysis is really going to be important as we move forward. And the overall survival was better than I would have certainly anticipated for the metastatic group for a real-world registry, and comparative, and even probably a little better than the published literature, I would say, for those groups. They didn't really reach the median survival, for instance, for the metastatic group, even at 2 years. So that, I think that's interesting. And that, again, I would emphasize that because the survival curves were similar, that provided the basis for at least saying that we could compare these QOLs, and that's why the QOLs were put together. I just wanted to say again. I'm happy to talk about the study, or we can just make it a more open discussion of, what are we doing with LIT? How does LIT look right now in this bizarre scenario? What kind of opportunities are there with LIT besides just killing tumor? I think it's a great opportunity to build new clinical trials, in fact, based on some of the concepts I mentioned just briefly, like increasing blood-brain barrier permeability potentially. I personally also think that it could act like an in situ vaccine, and so putting it together with immune therapy, for instance, in some of the trials I've mentioned, that's also an interesting approach.
So again, I'm just wondering, it struck me that high BMI, and
yeah, I know.
Was that just because it's a convenient sample, or was there screening criteria for NeuroBlate that required a other interventions be ruled out and not an option, and that this was the option because of the high BMI. How did that play out?
So I could tell you there wasn't a lot of cherry picking here because, I think there was a lot of talk initially among, my colleagues, for instance, of actually getting prospective trials done, randomized perspective. And, I think they're still out there, but they become difficult to fill if you make them restricted like the way you say. Like if you can't do anything else with lit, for instance. So it becomes difficult to compare lit plus something versus lit plus something else. So the idea of the registry was to really be all inclusive, and basically we just, the only things that were restrictive about it would essentially be like people saying no, or people saying no, I don't want to do this questionnaire. I don't think it was biasing it a certain way or cherry picking. I think that's just how these patients turned out to be.
So was that uniform across your 50 sites or the 14 sites?
That's interesting. I don't know the answer to that. Do you know if that's the case, if there's any skewing in that BMI? Because it's a pretty striking number.
Yeah, we didn't look across sites to see if there was any variability in some particular centers, but this is a national registry, so hopefully it's pretty representative of the patients that we're seeing across the United States.
Wow.
Yeah, it's pretty interesting. I was also struck by that when when the manuscript was coming together. But it's not like, it would be literally, for me, for instance, the representative for the LAANTERN study would show up for every single lit patient, and the only thing keeping them out of it is them saying, oh.
So it would be interesting to do a sub-analysis on the variable categories of BMI, and just for giggles, compare quality of life and that sort of thing, just based on BMI.
Just controlling for that. That's a great idea. I think that's a really good idea.
At our site, this was, there were not any cherry pick cases. Every patient was screened that was eligible for laser. And this, I'm not shy to say that is probably close to the average weight of many of the patients that we're treating, at least in Kentucky.
Yeah. I would say in St. Louis, that's probably true too. I don't know about, I'm trying to look at this author list. Maybe not for Dr. Hajipanias, perhaps in New York City, but I would say that that might be also the case for us in Missouri. That's a really good point. Yeah, next steps are again subset data analysis as we get larger numbers for each of these groups. But in fact, it might be worth doing that even with the data we have. I think that would be a great next step for the group, for instance. I know, for instance, Dr. Fetchy is looking at the subset of SRS refractory Mets and looking at actually a question. I'm so sorry, I forgot her name. She was asking me that if we're controlling for the post-lit treatments, which is an important point. And I think Dr. Fetchy was looking at different post-lit treatments in SRS refractory Mets. And he has some interesting data that's probably going to come out over the next couple months regarding that. There might be some, there might be something you want to do with lit in those circumstances. So I think if there are no more questions, I think that was a great discussion. I think a lot more needs to be done, but this certainly is an exciting technology, and it's certainly of great utility for the appropriately chosen patients. And we need more data. We need more data, and so we should continue this discussion.
From the crowd in New York, I will say that it's been really nice to be able to do the lit and get our patients in and out. I think
Oh yeah.
It's really been important because we just haven't had a PACU for 2 months now, and our ICU has been overrun by COVID patients. So
oh man, I can't imagine. Yeah.
Nice.
No, that's fantastic. Yeah, I would completely emphasize that. In fact, I have to say, we've been even changing sort of the way we think about some of these cases. Like if we had a large low-grade glioma, I was thinking, for instance, in a staged manner, doing lit for half of the tumor and then coming back 2 months later do the other half if it's greater than that 3 centimeter diameter. So we've been thinking about other ways that this situation might actually change the way we treat these patients. But that's great that you've been able to do that. It's also great to hear from you.
Yeah, good hearing you too. Hopefully we'll see each other soon.
Yeah. Any final call for comments or questions? If not, I think again, thank you so much for coming, everybody. I think this is important work. Obviously, it's proof of concept, and it's just the beginning. We'll be searching for more granular data as we move forward. But I think, again, this is an exciting opportunity for lit users. And please contact either myself or the Monteris team if you have any other questions about using laser.